maybe we can start with this specific entity, because we are talking about urothelial carcinoma, and most commonly it's bladder cancer. And the particularity in what we tried to do with Professor Houede was to design a specific trial just for upper tract tumor, because most of the time they are mixed up together in many trials, and we don't know what to do and how to read between the lines of the trial when we have upper tract plus bladder cancer mixed up together. So this trial was specifically designed for upper tract tumor. First particularity, it's quite rare. We had one trial a few years ago, ASCO GU 2018, if I remember correctly, the PUT trial, which was a game changer in the field, which was incorporated in the guidelines. And it was adjuvant treatment after radical nephrorectomy. So the design here is neoadjuvant treatment before surgery.
Yeah, it's very important to have specific trial for the upper tract urothelial carcinoma, because we don't have the same origin compared to bladder. So they have not the same level in terms of gene mutation, alteration, rearrangements. So they have some specific response to therapy, and we cannot take results from bladder and to do the same thing for the upper tract. So in this design, it was the first time we tried to combine immunotherapy and chemotherapy based on platinum salts. And it was very important. It was a pragmatic study. So we decided to enroll patients and to treat them depending on their kidney function with cisplatin-based treatment or carboplatin-based treatment. And at the top of that, we add Durvalumab as immunotherapy. They receive 4 cycles of treatment. We enrolled 50 patients over 3 years in 10 French centers. It was a very big collaboration between surgeon and medical oncologists to be able to treat these patients. The first question was the safety, and it's a very safe treatment. We didn't impact negatively management of the surgery at the time of the surgery. We have only a few side effects related most of the time to chemotherapy in terms of hematological toxicity, but it was a very nice surprise because we didn't have a grade 3 or 4 immune-related side effects in this situation. So in total, we have analyzed the pathological report after surgery for this patient. We obtained 30% of patients who have complete response in the cisplatin arm. It was a little more disappointing in the carboplatin arm, but in fact, 2/3 of our patients have done staging, and this is very important.
It's a positive signal, I would say, because on the pathological specimen, you have a signal of the fact that you obtain a tumor shrinkage due to the systemic treatment which was delivered before the surgery. So it's not the last and ultimate endpoint, but it's an immediate endpoint which is extremely interesting from that perspective.
Yeah, and we will follow, because for now, the last patient went for surgery in August 2024, so we will wait to have disease-free survival at 2 years to have a nice picture of the result of our treatment.
What we can say 2025 actually is that we are convinced that radical nephrorectomy alone is not a solution. And probably the equation of success for the patient is surgery plus systemic treatment. Should it be delivered after the surgery or before? We have not finally answered the question, but we have raised a very interesting scientific question. On top of that, there are pros and cons going into the direction of neoadjuvant treatment, for the simple reason that we are in a population where the median age is 70-75 years old. So if you take out the kidney, you put the patient in a difficult situation to receive a treatment of chemotherapy, which is cisplatin based, so depending on the renal function. So to optimize the situation most of the time, in the neoadjuvant setting, you are in a better situation to deliver the treatment.
And has our pathological reports prove that cisplatin is better than carboplatin in this situation? And we will go further with a phase 3 clinical trial design. At this time, we will have a comparator arm with chemotherapy alone. So we will enroll the patient and randomize them between chemotherapy alone based on platinum salt versus chemotherapy plus immunotherapy.
Well, so the experimental arm is going to add the immunotherapy on the old-fashioned good regimen, which is the standard today of chemotherapy. And so the comparison will come in the phase 3, but the stratification was done in the phase 2 based on the renal function. So we adapt and we were flexible a little bit on the regimen of chemotherapy we are delivering if the renal function was suboptimal.
And to be able to do this phase 3 clinical trial, we got a French grant, and now it's a big thing because 43 centers will be enrolled in the study. It's a very strong collaboration between urologists and French Association of Urologists and UTUC, which is a
cooperative group
group for medical oncology.
And we will expand probably outside the border of France. We'll see. We will initiate it in France, but we will see if there are opportunities to go to Belgium, Germany, Italy, and Spain. So we have some colleagues and we have a good networks of collaboration all over Europe that are keen to participate to this, I would say, expanded trial. Some surgeons are reluctant to give any systemic treatment before or after surgery, or especially before. We had this debate already for bladder cancer, muscle-invasive bladder cancer with neoadjuvant chemotherapy, saying subjectively that the surgery was more complicated after this kind of treatment. And what we saw in this feasibility trial, the phase 2 NAC trial, which was presented today with Professor Houede, that there was no negative feedback from the surgeons, and there were 10 centers, so not only 10 surgeons, but 10 teams of surgeons that were involved in the trial, and there was no negative feedback saying that it was difficult or generating more complication to perform the surgery. So on top of the fact that systemic regimen plus surgery is probably the equation to success, it does not make it more complicated to treat the patient properly.